Amy Max, Program Manager for the California Opioid Safety Network at the Center for Health Leadership and Practice, a program of the Public Health Institute. You are about to watch a webinar that has been condensed from its original format to provide specific content regarding strategies to reduce opioid supply. During the webinar, we will cover trends, existing strategies, and lessons from the field. The subject matter expert for this webinar is Dr. Matt Willis, our clinical lead for the California Opioid Safety Network. Let's get started.
So the way we've organized these Boots on the Ground series, as has been alluded to, is really recognizing that any strategy we adopt is going to fit into one of these three buckets. Either we're working to kind of turn off the faucet, if you will, of the inflow of opioids into our community, recognizing that this is largely an iatrogenic problem. This is an epidemic that started in healthcare, and we still have a lot of work to do in terms of reducing the supply of opioids. One important caveat for this conversation is that an increasing proportion of the opioids that are being abused in our communities are coming from other illicit sources. This webinar will not be focusing on those illicit sources, and we can discuss that as our strategies in those areas mature. So today's really primarily focusing on reducing supply within the healthcare system. This is a study that was done in 2016 that really modeled different ways in which we might approach the opioid epidemic strategically moving forward, and the ways that different strategies actually lead to different outcomes in terms of overdose deaths over time. The bad news is that the top line is actually what we would see if we didn't do anything differently, and seems to actually correlate to the trends that we're continuing to see. The good news is that the most optimistic scenarios, that bottom line that leads to 70,000 fewer deaths than the worst scenario annually by the year 2026, assumes that we're optimizing strategies in both reducing opioid supply, reducing opioid demand, and reversing overdoses, and stigma reduction and other strategies that we'll be discussing. So one way of thinking about our goals in the California Opioid Safety Network is to really be that state that realizes that more optimistic scenario. So why it's important to reduce opioid supply? This shows that from 1999 to 2010, we saw a dramatic increase in the amount of opioids being prescribed and a corresponding and linear increase in the number of overdose deaths and treatment admissions. We also see in geographic locations the same pattern. So places that have very high opioid prescribing also have high rates of overdose deaths. This is a map of New York City with all the boroughs, and it shows that Staten Island was a place that it was an outlier in terms of prescribing and also in terms of overdose deaths. We know that this epidemic is highly localized, even in the state of California. So the strategies that you adopt are going to need to be tailored to your own setting. This is a study that came out in MMWR just last year that showed that when we're prescribing what we think may be short-acting opioids for acute pain, we may actually be setting the stage for long-term addiction. 20% of people who are given a 10-day supply of opioids acutely are actually taking that medicine 1 year later. So guidelines that help, and safe prescribing practices that help reduce that number of first days are important. The same is true for opioid refills. And then finally, 3 out of 4 people who use heroin are actually report using prescription opioids prior to the use of the illicit opioids. So how did we get here? This is, I think, familiar to many of us who worked in healthcare. I was in medical school from 1995 to 2000. And I certainly was taught that pain is the fifth vital sign, which was a way in which pain was marketed by the American Pain Society. On the left here, you have the amount of money that produced pharmaceuticals actually invested in marketing OxyContin, and we see that there was more than $100 million invested in just the marketing of that one product once it was approved for the management for chronic pain in 1996. And we're promised in this middle slide here that Vicodin will help our patients become muscular and strong. And it also, interestingly about this Vicodin, as it sort of points to this convenience of this medicine. It says this is the strongest analgesic you can phone in. It doesn't require a triplicate, sort of pointing to the convenience and the way in which convenience actually leads to choice around prescribing, which we'll get to in a bit. So how do you know what your current prescribing patterns are in your jurisdiction? Many of you may be aware of the California Opioid Dashboard. By county, the prescribing rates in a variety of ways. One is on the left here, you have the number of people taking very high doses, above 90 morphine milliequivalents per day. So these are the chronic high-dose opioid users. It also shows the number of milligrams of morphine actually dispensed into the community as a whole over time. So the first strategy that we're going to get into is safe prescribing guidelines. So the use or adherence is generally voluntary. Guidelines use influences practice norms, so it sets a standard for what would be accepted as normal and the standard of practice for a given community. Guidelines influence clinical decision-making, but don't force clinical decision-making. Guidelines also, in terms of the coalitions, what we find is that because of that geographic specificity around prescribing that we saw in Staten Island and other places, guidelines offer us a regional opportunity to set regional norms. So in Marin County, for example, we have 3 hospitals, 3 emergency departments, and our guidelines allow us to set the standard for across all 3. So that a patient might come into one emergency department and recognize that they're going to get essentially the same standard as they would get in another emergency department. So across the systems within the region, it establishes local norms. This is just an example of guidelines that are available that we developed here in Marin County. On the left, we have our emergency department guidelines. Actually, on the left, it's our chronic pain management guidelines for outpatient settings. And on the right, there's our emergency department guidelines. These are actually available in an editable form. One of the benefits of the Boots on the Ground series is that we'll be making available to all of you some of these resources that we're showing. So you can actually get and download and edit and change the logos of any of these products in your own setting. This is just the power of coalitions in prescribing guidelines. These are prescribing guidelines for the Monterey County coalition and some of the settings in which the guidelines were adopted. So the next stronger element of influencing prescribing and safe prescribing is around decision support tools. So decision support tools support adherence to things that have been decided as important within the guidelines. Examples include electronic medical records flags, where flags might be around high doses or risk recombination. So if someone is taking an opioid and a provider chooses to also prescribe a benzodiazepine, there would be a flag that might come up and say, are you aware this patient is also taking an opioid? You might consider an alternative. Also flagging risk factors for misuse. So if a patient has a substance use history, it would actually be featured prominently within the EMR as the physician is ordering medication so that you're able to take that into account. Another form of decision support is defaults to lower doses. For example, in the Kaiser system in Marin, the default for some of the short-acting opioids changed from 30 tablets to 15 tablets just by changing the drop-down menu available to ER physicians as they're prescribing. This is actually, unfortunately, embarrassingly powerful as a way of decreasing opioid prescribing because of what we know about the way physicians make decisions is often based on what's convenient and immediately available to them and what is suggested by the tools they have. The other important decision support tool is cures. So one of the main strategies that many of the coalitions have adopted is trying to promote the cures use among their physicians. Cures, as most know, is our physician drug monitoring program for the state of California. It allows any clinician to see the opioid and other controlled substance prescribing history for any patient they may be considering prescribing to. This is what the patient activity report looks like. Basically, any physician who's registered in Cures can just look up by name and date of birth any patient's prescribing history with regards to controlled substances. And what you will generate through that is the patient activity report, which is just this basic spreadsheet that has each prescription that patient has received, and it will tell you what the drug name was, the dose, the other prescriber who prescribed it, and the pharmacy that it was filled. using cures is important, and it's one of the core strategies that's being sort of advanced nationally. And this is a study out of Massachusetts that shows that areas where patients were doctor shopping correspond very highly to areas where there were overdose deaths. We'll now talk about policies and protocols. This is the strongest way of influencing, prescribing, because it's actually removing it from the domain of physician choice, but making it actually sort of a forcing function for adherence to those practices that we know to be the safest in prescribing. For example, formulary changes. Partnership Health Plan removes Xanax from their formulary. We know that many people who overdose are overdosing on combinations of opioids and benzodiazepines, and Xanax was pulled from the formula. Xanax is a short-acting and highly addictive benzodiazepine. So taking that example, we might think of an approach to preventing benzo-opioid co-prescribing might be in guidelines, sort of mentioning that as a risk, and physicians, as we have in our guidelines, physicians should be aware of the risk of co-prescribing and take this into account in their prescribing behavior in sort of a more vague way. In the decision support tools, we might have the prompt that would say, if you're trying to order 2, that it would actually suggest that you pull an alternative in more real time as you're making that decision clinically. And then the strongest would be just not allowing some of those decisions to be made unless there's a special process like a prior authorization or a special request to have a formulary change. Final element around policies would be legislation. So as an example, cures use is currently in more of a decision support mode because it's a choice. So physicians can choose to participate or not. Cures will be mandatory starting in 2019. The next tool available to us as a coalition is academic detailing, and it's essentially borrowing the methods that we know were effective for our pharmaceutical representatives who would travel around to different clinics and educate clinicians specifically to try and influence their prescribing practice. It focuses on outreach and education to providers. We recognize that a high volume of opioids come from a small number of prescribers. So in Marin County, for example, we have about 80% of our opioids come from 15% of our providers. Many of them are orthopedic surgeons and certain primary care clinics. So we actually were able to pay specific visits to those settings and talk to them about prescribing behavior, give them some of the data, and do sort of a more tailored message to that particular group based on what we know about their prescribing practices. We also know that dentists, for example, are the highest prescribers to people aged 15 to 19. We can reach out to our dentists and let them know about the unique features of sort of the adolescent brain and risk of addiction at that age based on their prescribing to people, having wisdom teeth removed as a form of academic detailing. Also sending letters to different providers, educational forums, grand rounds, CME brown bags, and we can share some of the presentations that we've offered and different coalitions have offered in grand rounds or CME settings to their local providers to give a sense of what the most effective messaging is. Another way to reduce supply that we don't often talk about is not just reducing the inflow, but also increasing the outflow of medicines from our community. Misused medications we know often come from family and friends, especially in young people. There's a SAMHSA study that said about half of the medications that young people were misusing were first obtained from family and friends through informal networks and not from physicians. So by reducing the number of opioids that are in our medicine cabinets, we can actually help address the opioid epidemic locally through offering people opportunities to get rid of unused and unwanted medications. This is an example from our report card here in Marin County that we're trying to increase the number of the pounds of medicines that are actually returned in our newly established take-back system with a SMART goal of a 10% increase annually. There are a series of, there are a number of counties now that have actually entered into a relationship with pharmaceutical manufacturers for them to fund a network of take-back locations through local ordinances. This is something that has been proposed at the state level and has not been successful in terms of a state-level legislation in the state of California. California, but many jurisdictions have been moving forward independently on this. This is what our little website looks like in terms of the guiding people to locations for take-back. We have now 25 locations across the county funded by pharmaceutical manufacturers. So another piece of reducing supply is actually working more effectively with our law enforcement partners as we get deeper into this illicits as a potential source of opioids. This relationship will need to continue to grow. Obviously, the Federal Drug Enforcement Agency investigates very high prescribers and pill mills. Locally, though, we can actually have stronger relationships with our local law enforcement, even in terms of reducing supply. Examples are district attorney letters that can actually go from a district attorney as people are arrested for illegal use of opioids, and sending those letters to prescribers to let them know that a patient of theirs was arrested for selling medications. And then coroners, some jurisdictions, the county coroner or medical examiner will actually send a communication when someone has died from an overdose to the prescribers they find in the cures report who had prescribed to that person, non-punitively, just to let them know that they might want to take that into account in their future practice. This is an example of the letter that we have in Marin County, where our district attorney basically says, "Dear, physician, it's come to our attention that X, your patient, a criminal complaint was filed against that person." It tells a little bit about the situation, and then it was a partnership between, our team, Health and Human Services, the Partnership Health Plan, our Medicaid provider, and our clinicians, our different health systems, to actually reach back and just let them know. And we got generally positive feedback on this, because as we know, many times physicians that don't actually know what's happening with the medicines they're prescribing. We're going to hear now from two different coalitions who are advancing two different ways of promoting safe prescribing. The first will be from Casey Grover. Casey is an ER doc and a friend and an awesome champion in this space for, across the state. He and his wife, Reb Close, are working in many sort of progressive ways in Monterey County in safe pain management from emergency departments, but also in connecting people to medication-assisted treatment from the ED. And some of their safe prescribing patterns are what we're going to hear about today in terms of some of the decision support tools. Casey's been working in Monterey County at CHOMP since 2013, and he's the chair of the Division of Emergency Medicine. So I'll hand it over to Casey now.
In Monterey County, we have a unique mix of hospitals, and I work at the private hospital in the Monterey Carmel area. And for the longest time, we've known that there's been a problem with opioids, and we've started working since 2005 and 2006 on trying to address chronic pain and opioid misuse. And one thing that has been very interesting to watch is, as we would tell our colleagues, please don't use opioids, or can we please reduce opioids, the response was, that's fine, but when the patient's in pain, I have to do something. So can you please give me some options? And the other thing that also came up is, as we all know, physicians tend to get pretty stuck in their ways, and change can be difficult. And so we tried to brainstorm ways of, number one, what can we do to expand options for pain management? And number two, how can we make the right decision the easy decision? And I apologize, I'm in the hospital, so if you get an overhead page, I'm sorry. So looking at our first intervention, and I can't take credit for this as an idea, it was actually our department director who was trying to make us work faster, but we have pre-printed scripts. So in Monterey, we're still using paper prescriptions, and when the paper prescriptions are blank, it takes the same amount of time to write for naproxen as it does for Norco. You have to write up the name of the drug, the quantity, the directions, sign it. And so our director realized, well, we use a ton of medications on an ongoing basis, antibiotics, medicines for allergic reactions. Why don't we just make a pre-printed script, which you can do for non-scheduled medications? So this is a zoom in of what's in our pain and nausea section. And it used to be that when people came in with a sprained ankle, it was just as easy to write for Norco as, again, I said, as it was to write for naproxen. But now if somebody strains their back, with 4 check marks, I can give them naproxen, Flexeril, Lidoderm, and Voltaren, which gives them 4 options for pain management without any opioids, and it's actually faster than writing for an opioid. So regrettably, because we have paper prescriptions, it makes it very difficult to track the changes in outpatient prescribing from the emergency department. But I know personally, now that I can go check, naproxen, Flexeril, Lidoderm, Voltaren, that's my default. I rarely write for opioids unless I specifically have to take the time to get out the blank prescription pad and write for it. So again, this was an example of, number 1, giving people better options for non-opioid therapy than just Motrin and Tylenol. And number 2, also making the easy choice the right choice. The second thing that we also worked on was trying to come up with order sets for pain management. And this comes back to the same thing of we'd have a migraineur in the ER, and they didn't feel that much better with Toradol. And the providers are saying, well, the patient's in pain. You tell me not to use opioids. I have to have other options. So I sat down with one of our hospital pharmacists, and we created a pain management order set. And I apologize for the font being small, but I can walk you through it. So I basically created first-line therapies, which were non-opioid, second-line therapies, which are the opioids that aren't as desirable, and then the third-line opioids, which are the ones that people seem to like the most with issues with chemical dependency. And as the group probably knows, it's Dilaudid and oxycodone that we were trying to stay away from. So up here, and the first red box on the top is first-line oral medications, and that includes oral anti-inflammatories and acetaminophen. The second box is to highlight then the category of injectable, either intravenous or intramuscular pain management, and that predominantly is ketorolac. We do carry intravenous acetaminophen, but our pharmacy wanted us to not have that as a standardized order because it's relatively expensive just yet. And then this third box is all migraine medications. And what's incredible is, I don't know if I can count, but there's probably 15 plus medications there. And I have to give credit to one of our ED pharmacist, Brian, for this, because he went through and basically did an evidence-based research of the literature to find out which are the most effective medicines for migraine that are non-opioid. And so we have dexamethasone on there, we have sumatriptan, rizatriptan, we even have DHE, we have valproic acid, and so we've really been able to avoid going first line to opioids for migraine. And so it's great. It's a single order set. The physicians all know where to find it. And it's fantastic that we can have folks look at this order set and choose a non-opioid option. This is the second part of the this is the second part of the pain management order set. And the first box is to highlight adjunct therapies. And this was something we were doing with things like topicals, things like prednisone for radicular pain. We even have transcutaneous electrical nerve stimulation or TENS units. I can ask my staff to set up for a nerve block. We have nitrous oxide. Same thing, just trying to make the non-opioid options available. And then lastly, we also have a low-dose ketamine infusion set, and we've tried to use that for more special patients who don't respond to really any of the other therapies, and we have a protocol written up for that for our hospital. And just going forward one slide, you can see I'm highlighting 2 medications that have been extremely helpful and very well received by patients, and that's lidocaine patches, the 5% Lidoderm, and then the topical diclofenac, the 1% Voltaren gel. And as a patient, I used some Voltaren on my knee this morning. It works absolutely fantastic. And looking at how that's actually been received by our emergency department staff, here's a comparison of 2012 to 2014 versus 2014 to 2016, and looking at non-opioid therapies. And you can see we've increased our use of Lidoderm by over 300%. I realize gabapentin has some issues, but we've certainly increased our use of this as well. And just to clarify, these are doses given in the emergency department. And then we've also increased our use of Toradol and ibuprofen. So to kind of take home the point, if you give physicians the option, at least in my emergency department, and hopefully that's applicable elsewhere, they use them. And I can't tell you the number of times that lighted derm patches have been great in people over 85 or even in their 90s who have fallen, compression fractures, contusions. They've been great. And lastly, this is from the California Opioid Dashboard. This is a number of the opioid prescriptions by patient location, and you can see Monterey counties in blue, and we're seeing basically a slow downward trend as compared to the state average, which is relatively constant. And in our county, we have 4 hospitals with emergency departments. Mine is where our drug safety efforts have really started and are being led from, and it's great to be able to develop something, have a protocol, talk to my buddy who's, 30 miles down the road in Salinas at the neighboring hospital, share it with him or her. We've really had the please steal what we are doing approach to this, and we've had some interest from the other hospitals who are slowly starting to develop the same approach. As an example, one of our county hospital for the county of Monterey doesn't even have buprenorphine on formulary, so they're working on that whole pathway, and they're asking our pharmacists and me and my staff, and we're sharing protocols and helping them to move forward. So it's truly an effort that will spread throughout the county.
Right. So the next speaker will be James Wilson. James will be coming at this from another perspective of a rural coalition in Northern Sierra up in Plumas County. James has been one of the early leaders in coalition space, and really has been championing a lot of the work that's happening up in the Northern Sierra region. He's the leader of the 4-county coalition, which spans Plumas, Lassen, Sierra, and Modoc. They've done a lot of excellent work in reducing the amount of overprescribing and reducing opioid overdose deaths, and they're working across the spectrum of care, incorporating prevention and harm reduction principles. So I'll hand it over to James.
All right, great. Well, thank you. So I wanted to just first off just talk about a little bit about our coalition and about the region that we have. As Matt pointed out, we're a 4-county coalition. It's Modoc, Lassen, Plumas, and Sierra. It's actually a really big area. It's really spread out. We joke about how it could be its own state, and it's really actually the size of Maryland, but it only has 1% of the population. So that kind of gives you an idea about how spread out, how rural it really is. We started this work I'm going to be talking about the guidelines and implementing just a regional universal guidelines that we all kind of agreed upon. We started doing this work out of the public health office here in Plumas County. This is where we actually processed the death certificates for our county, and we noticed that there was, just a really high rate of overdose deaths. At first, when we were taking a look at it, we thought that it was kind of a result of drug diversion or illicit use. And on closer look, a lot of these folks that were dying, and they also had really high prescriptions themselves. So if you look at this is a graph of all 4 of our counties, Plumas, Lassen, Modoc, and Sierra, and it shows over time, over a 6-year period, what our prescribing rates were. We compare it to California's rate, which you can see California as the line at the very bottom in yellow. And California, although it's risen, it's been staying somewhat steady as far as the number of prescriptions per 1,000 residents. It's been a little bit between like 600 and 700. If you go up, the line in red at the very top is Plumas County, and it was seeing the highest prescription rate. Correlating with that, it was also had the highest overdose death rate. And so we really figured out that we needed to do something. Well, in that line that's there, the big black line, that was when we started realizing that this wasn't due to diversion, but it was due to prescription, and it was when we realized we had really, really high prescribing rates and needed to do something about it. So that's when we formed our coalition, this black line. And you can see there was some work that was done before that. But for the most part, our rates were pretty much doubled what the states were. We were prescribing, 1,300, almost close to 1,400 prescriptions per 1,000 residents. We we decided we needed to do something, and one way to do it was just, well, dramatically drop the number of prescriptions. I showed this graph to a doctor in our region, and he thought that maybe it was just due to a handful of high prescribers that have since moved away. But the docs that he was referring to just moved away to a different county in our same region. So it didn't really affect it as much, especially since there's a cross-correlation of patients going into our, neighboring counties, hospitals, and clinics. You can see that once we did start doing something about it, once these guidelines were put into place, there was a pretty dramatic drop between 2015 and 2016 in the amount prescribed. We started out, when we formed the coalition, we started out with one of our action teams was the Safe Prescribing Action Team. And this was really kind of like what I like to refer to as the Doctors Club. It was comprised completely of doctors and myself, who is not a physician, and it included physicians from just across the region. So we had representation from all the major hospitals and a lot of the clinics. Our main objective that we decided upon was to put prescribing guidelines in place in every hospital of our region. And these were going to be guidelines mainly for chronic pain. It was actually, when it came to the emergency room guidelines, we were able to kind of quickly decide upon what guidelines looked good. For chronic pain, we originally looked at 2 local guidelines. One of them was in place. It was from Eastern Plumas Healthcare, and then Plumas District Hospital had some guidelines that it was looking at. It hadn't completely implemented them yet, though. We also looked at Marin's guidelines and San Diego's, and there was a lot of discussion amongst the providers from the action team just about which guidelines that we should actually universally agree upon. I actually looked back at our minutes from these meetings, just getting ready for this, and there was just so much discussion about the tiniest details. As a non-physician, I didn't really understand what the big deal was, and it was also kind of frustrating. I figured that we could just grab any guidelines and put them into place. Well, part of the problem was, I think that each hospital was linked to its own town, which was geographically and culturally just very separate and very different from the other towns and regions and hospitals in the area. So each one of them wanted to kind of maintain its own unique sense of autonomy, and guidelines was one way that it was able to reflect this. It was around the same time that when we're looking at all these and arguing about which ones would work, the CDC released its recommendations for guidelines. This was around the beginning of 2016. And partially was, I think, maybe because it was the authority of the CDC being something that was already universally accepted as, an authority figure. It was just agreed that it was kind of a good middle ground for all the different guidelines that we were considering. And it just, the conversation about just what details should be included and which ones should be omitted just ceased completely, and these guidelines were regionally accepted and aligned. So it really saved us a lot of trouble. There was some posters that were already ready to go. We just had to download them and print them up. So we were able to print those up and put them in all the hospitals and clinics, and ever since then, that's just been basically the ones that were followed. And that's the story of how we got our guidelines in place.
So getting to available tools and resources, this is a graphic that represents the diversity of partners that come together in an opioid safety coalition, and it's something that any of you should take advantage of in your own internal communications in your community about what a coalition might look like when it's actually truly intersectoral and engaging all the partners that we might engage. There will be, an ever-growing sort of resource bank for coalitions around specific tools. We know that most of us don't have the bandwidth to build these things from scratch.
Thank you for watching this video. Please visit our website, CaliforniaOpioidSafetyNetwork.org, to access tools and resources, information on funding opportunities, and more videos in this learning series on opioid safety strategies and coalition development.